Thank you, and I appreciate the invitation. Fortunately, I have no disclosures relevant to this talk. I'm going to be using interchangeably the term critical limb ischemia or chronic limb-threatening ischemia. Essentially, they're the same thing. Critical limb ischemia was defined in 1981 by an international vascular group, which encompasses resting pain, ulcers, or gangrene. This new term of chronic limb-threatening ischemia appeared in the new European Society of Cardiology and European Society of Vascular Surgery guidelines, which essentially what they do is that they exclude any non-ischemic reason for critical limb ischemia. So, having said that, we'll review implications for critical limb, know the strategies for optimal medical therapy, and assess the outcomes of optimal medical therapy. Now, this is a very old slide that most of you have seen from Michael Creaky over 30 years ago, but it still holds true. If you have athero anywhere, you have it everywhere. So patients who have peripheral arterial disease with severe symptoms, some symptoms or no symptoms, that actually carries or confers some sort of implication in terms of morbidity and mortality. And as you see here in this prospective cohort study, the more progressive the disease, the higher the event-free survival, or the worse event-free survival, I should say. And if you look at ABI, the worse the ABI, the worse is the major adverse cardiac and cerebrovascular events. Now, this is a table that came from the REACH registry that enrolled over 9,000 patients in 44 countries. And as you see, the worse the presentation of disease, the worse is the composite endpoints of myocardial infarction, stroke, or death, particularly in patients who have critical limb ischemia and amputation. Now, as I was told many years ago, if you have rust in the basement, you have it also in the attic. So if you have athero in the legs, you probably have it in your thing, you have it in your heart, you have it in your brain. So optimal medical management for CLI is not targeted at the legs, it's targeted systemically because of the systemic nature of atherosclerosis and includes smoking cessation, antiplatelet therapy, lipid-lowering therapy with statins, antihypertensive medications, glycemic control, anticoagulation, and vasodilators. So smoking decreases the likelihood of amputation, the need for revascularization, and improves arterial bypass grafts. It is known to improve walking distance, in some instances, improves pain, but more importantly, it improves survival. And as you may expect, it carries a Class 1A indication for counseling for tobacco cessation and also for developing a plan for quitting tobacco smoking, which includes pharmacotherapy, nicotine replacement, and as well as referral to smoking cessation programs. Now, antiplatelets have come into fire recently, particularly in primary prevention for elderly patients who are asymptomatic. However, in patients who already have established peripheral arterial disease, multiple studies, including large meta-analysis, have shown that it decreases serious adverse vascular events. And as you may expect as well, it also carries a Class 1A indication for monotherapy with aspirin 75 to 325 milligrams daily or clopidogrel 75 milligrams daily to reduce myocardial infarction, stroke, or vascular death in patients who have symptomatic peripheral arterial disease. As you may remember, Capri has shown many years ago that clopidogrel 75 milligrams daily was superior to aspirin in reducing cardiovascular events, particularly in patients who have peripheral arterial disease. However, it was unclear whether dual antiplatelet therapy had any value for secondary prevention in patients who had not had revascularization. However, Charisma answered that question, the addition of clopidogrel to aspirin, in that these patients did not improve cardiovascular outcomes. The next question to answer is if other more potent P2Y12 inhibitors would do the trick. And the Euclid trial demonstrated that ticagrelor, 90 milligrams twice a day, was not superior to aspirin in reducing major adverse events. What about statins? Statins have an indication. They improve claudication as per single center studies. They may slow the rate of functional decline among patients with peripheral arterial disease. Is associated with improved patency for infrainguinal bypass and is associated with a decreased perioperative complications among patients who have gone surgery. And as you see in this forest plot from the heart protection study, there is a benefit in all major endpoints with usage of statin therapy, including a major coronary event, stroke, or revascularization in patients with peripheral arterial disease or not. And the benefit extends to improve a walking distance as early as 3 months, as you can see in this study, where simvastatin was used and compared with placebo. And as you may expect as well, again, a class 1A recommendation for statin use. However, most of you will likely use high-intensity statin, that is atorvastatin 80 milligrams PO daily, or rosuvastatin 40 milligrams in patients who are less than 75 years of age. As you know, between 75 and 85, the data is not very conclusive. You perhaps may decrease the dose by half. What about antihypertensive therapy? It also has gained a class 1A recommendation. It does not discriminate on the type of antihypertensive medication that you use. However, ACE inhibitors and ARB has gained a 2A recommendation, but it doesn't necessarily mean that is superior or inferior to other antihypertensive therapy. It has also been shown to improve walking distance as compared to placebo. In terms of diabetic therapy, there is no specific target except that you want to treat your patients to obtain a hemoglobin A1C less than 7%. And in terms of anticoagulation therapy, the guidelines give a class 3 recommendation, or is contraindicated in patients to reduce the risk of cardiovascular ischemic event with PAD. However, this guidelines predate the COMPASS trial, which was published in the year 2000, that demonstrated that the addition of rivaroxaban 2.5 milligrams twice a day, in addition to aspirin, reduce cardiac and cerebrovascular events, particularly in patients with peripheral arterial disease. In fact, the sub-study of COMPASS demonstrated that it also decreased major adverse vascular events. In terms of other pharmacotherapy, such as prostaglandins and angiogenic growth factors, none of these have gained any class 1 or 2A recommendation. It is uncertain whether they have any benefit or not. You probably have seen this graph in the past. It shows that the number of surgeries have decreased, as well as amputation, while endovascular therapy has increased. Now, that doesn't mean that we've resolved the problem. It means likely that medications are also working in addition to the work that we do in the laboratory. Finally, I'd like to invite you to the New York Coronary and Vascular Summit, which this year will be held in New Orleans on Friday, October 6th. Dr. Krishna is going to be doing a live case for us, as well as Dr. Samin Sharma, and 2 live cases coming from Stony Brook. Thank you.